Hey, everybody. Hi, I am Dr. Dana Gibbs. It's good to see you guys. So today, for our Tuesday Live, my topic is, so if you think PMS is bad, just wait until menopause. Taking hormones isn't natural, and some other menopause myths that we all need to unlearn. So anyway, I am Dr. Dana Gibbs. I am a hormone and thyroid doc in South Lake, Texas. Let's get started. So, if you are listening to this and you're not a physician, please keep in mind that scientific proof is not nearly as black and white as people think. And in order to make treatment decisions for individuals, sometimes we have to consider evidence that's not nearly as absolute as we'd like. This is not meant to be medical advice, and you should consult your own physician for any medical issues or diagnoses that you may have. All right, so today I want to address several myths or erroneous beliefs that people seem to have about menopause and about menopausal hormone replacement. So I use kind of a goofy title there. So let's define menopause versus PMS first. So PMS is premenstrual syndrome, or a set of symptoms that happens to some people prior to the onset of their menstrual period. It's caused by the rapid withdrawal of progesterone at the end of the luteal phase of the menstrual cycle. And it leads to an imbalance in the neurosteroid called allopregnanolone compared to progesterone, which that leads to mood changes and lots of other negative things associated with your periods. Perimenopause and menopause. Perimenopause is the period leading up to menopause that results in the fluctuation of hormone levels once again, but that occurs starting sometimes 10 years or more prior to the onset of actual menopause. And then it gets worse and worse over the period of time, and then it levels out to nearly nothing after menopause, when the and it's not a switch, it's a roller coaster. So this is a result of the ovary slowly losing the ability to respond with hormones to the pulses of pituitary signals as the remaining cache of eggs runs out. So let's go over some myths and see what we've got. Well, the first myth is that menopause has a well-defined beginning and end. So scientists use a definition of menopause as the moment that it's been 12 months since you had a period. It's very arbitrary, and it's definitely not the beginning, and it's absolutely not the end of it. So menopausal symptoms start in perimenopause, sometimes as long as 10 years before. And I'm not really going to go into all the symptoms of perimenopause today, but they are not fun, and hot flashes is only part of that. And menopausal symptoms can persist for some people for 10 or more years after menopause, meaning like the vasomotor symptoms, the hot flashes, and that. And many symptoms associated with withdrawal of sex hormones just continue to get worse the longer a person who once had ovaries that were functioning is alive on the planet. So it is not a switch, it's a roller coaster. Now, myth number 2, taking hormones isn't natural. All right. So you can debate about that, but what's natural is to die by the average age of about 58, which was the normal lifespan of Americans 100 years ago. And incidentally, that's about the age I am now. But women are now living on average 20 plus years longer than that. And what's natural for those people is a sharp and continuous rise in cardiovascular disease, bone loss with fractures, colon cancer, dementia, and a condition called genitourinary syndrome of menopause. 84% of women will end up getting this. And these are all direct consequences or dramatically increased by the loss of estrogen. And the longer a woman is alive without estrogen, the higher the risk of all that stuff goes. In fact, in early menopause, which is defined as menopause before the age of 40, it's listed as an indication to take estrogen to reduce those risks, which are pretty much ridiculously high in women who have very early menopause. So if we feel like it's indicated from age 40 to 50, then why are we dropping it then? So my family history has all of those risks, the dementia, the heart risk, the bone loss. And I certainly intend to do all I can to reduce my risk, particularly after my mom, watching my mom suffer with all these things. And she's now 81, and just barely hanging on. Um, okay, so maybe it's not natural, but it's also not healthy. Anyway, speaking of natural, let's spend a moment on the word natural in regards to supplements and hormone preparations. So, Premarin is natural for a horse. That is estrogens that come from pregnant mare's urine. And many of those compounds are not ever seen in human physiology. Yams are natural, but they are a very weak estrogenic compound that is not all that similar. I mean, it's somewhat similar, but it's more of a blocker than it is it'll bind to an estrogen receptor, but it's not really an equivalent of estrogen. In order to make it equivalent, it has to go through a chemical process, which then makes it bioidentical. So there's this big notion out there of what bioidentical is, and what my definition of bioidentical is chemically indistinguishable from the hormones that are naturally present in the human body. So that's bioidentical to me. The chemical formula, the molecule is exactly the same as what your body makes. So there's this big notion out there that bioidentical is always compounded and it's expensive and it's not FDA approved. And this is wrong. So progesterone and estradiol and testosterone available in FDA approved prescription forms are all bioidentical. There are some synthetic hormone like drugs that I feel have either been proven dangerous or questionable. And most of the progestins that are not progesterone fit this. But it is perfectly possible and not difficult to design a hormone replacement regimen for a woman or a man, for that matter, using all FDA approved compounds and prescription medicines. All right. So, myth number 3, menopause is mostly hot flashes. All right. So if you don't have those, you don't need to do anything, right? No, that is not true. 1, menopause is not mostly hot flashes. 2, this goes right along with that thing where you need to stop your hormone at 10 years and you shouldn't start until after you actually hit menopause. These are really outdated dogmas because estrogen starts to drop sometimes 10 years ahead, and estrogen continues to drop after menopause till it is more or less undetectable. And estrogen does a lot of things in your body. So it improves your skin, it improves collagen and elastin, it improves insulin resistance, so that weight gain around your belly. It can help prevent macular degeneration. It helps treat joint pain. It improves sleep, sexual function. It decreases the incidence of Alzheimer's and all causes of dementia and neurologic disorders in postmenopausal women, including depression, mood disorders, and anxiety. There's also this newer named or renamed diagnosis called genitourinary syndrome of menopause. And I'm going to save really detailed talk on that for another day. But this is the loss of tissue mass and elasticity in the perineum of a woman who no longer has estrogen. the urethra, the labia, the vagina, clitoris, that results in changes of pH, increased bacterial counts, bad bacteria anyway, pain with sex, urinary tract infections, incontinence, bladder and urethral prolapse, among other debilitating things. And it occurs in some studies I saw said 84% of women, and it gets progressively worse the longer you have been deprived of hormones. And it is 100% treatable with safe and FDA approved vaginal preparations, even if you're currently under treatment for breast cancer. So, given at the correct time, which is basically, in my opinion, as soon as your hormone levels start to drop, and continuing as long as you want to control all these risks, the hormone reduces those risks. And there are FDA approved indications for bone loss and GSM. So these problems are not just annoying. Some of the time they're deadly. I mean, if you are old and you have no hormones and you have lost all your bone mass and you break your hip, that's very frequently prelude to horrible quality of life and or death within a year. All right, myth number 4. Testosterone is the men's hormone and estrogen is the women's hormone. Men don't have estrogen. Wrong. And once you start getting into menopause territory, men generally have quite a bit more estrogen than unsupported women. And this is why men keep their bone mass longer than women, because they actually still have quite a lot of estrogen floating around. And so their heart risk doesn't take a dramatic spike up the minute they hit age 55. Theirs gradually and slowly increases over time. The next one is women don't need testosterone. Women don't have testosterone. Well, that's also not true. So women do better with a balance of all the hormones. And you can frequently get a natural or premenopausal level of testosterone by taking low dose DHEA, which is actually an over the counter supplement. And the reason I sometimes recommend this is because testosterone is not FDA approved in women's sized doses, which are generally about 10% of what a man would need. And of course, it's always important to check these levels if you're going to supplement. And myth number 5. Estrogen causes breast cancer and increases risk for a host of other serious conditions, uterine cancer, dementia, coronary artery disease, early death. These are all claims that came out of the early findings of the Women's Health Initiative when the authors went to the press before the study was even published and trumpeted this to the masses. This has really been probably the single biggest, I don't know, I almost want to call it a crime, perpetrated on women, or a boondoggle, if you want to say that, in this century, because most of that stuff was found not to be true. The problem with it is package inserts on every kind of estrogen product are subject to what's called a class labeling rule by the FDA, which means that every hormone product out there, even vaginal estrogens, which have now really been proven to be completely safe, still say that you can have increased breast cancer risk, heart disease, dementia, and early death. I mean, that's literally what it says on the package inserts. And this has been shown definitively not to be true. Even the transdermal patches, the creams, and the intravaginal estrogens do not increase cancer, heart disease. They don't. They just don't. Um, but as far as the Women's Health Initiative, guess what? Neither do the FDA approved original oral estrogens that they use cause increased breast cancer. So I addressed this in an earlier live where I talked in detail about the Women's Health WHI or Women's Health Initiative study that was begun in the late 90s. So in the final analysis that came out in 2020, their mea culpa conclusion was that even the oral estrogen alone, without medroxyprogesterone, by the way, actually slightly decreased breast cancer incidence and mortality, even given in the faulty protocol that they used at the time, where they were giving it to women who had not been on hormones and were way, way past menopause. So what they did nicely prove is that the longer you go without hormones, the riskier it is to start them in terms of heart disease and dementia in particular. So before 10 years after menopause, actually decreases those risks. 10 to 20 years-ish seem to be neutral, and over 20 years definitely seem to increase the risk of heart disease and dementia. And the theory about why this is something called the healthy cell hypothesis. And what this is that as you withdraw from estrogen, your cells lose elasticity. And the cells that are in your blood vessels that have the atherosclerotic plaque within them are very, very stiff, but they're holding on to that plaque. Now, if you then suddenly go back and give estrogen to that person, then it improves the elasticity of these cells that have the plaque in them. And some of them will break open or slough off and then go and increase heart attack risk. So it's not good to wait 20 years and then start on hormones. It's not a great idea. So if you want to know some modifiable risk factors that actually do increase breast cancer, how about obesity? How about lack of exercise? How about alcohol consumption? Alcohol consumption has now been shown to increase breast cancer risk by about 15% in women who consume 3 drinks a week or more. And the WHO now indicates that there's no safe level of alcohol consumption in regards to breast cancer risk. Okay, myth number 5. Breast cancer is a more dangerous diagnosis than heart disease. I'm going to say, once again, no. I'm not trying to minimize the risk or incidence of breast cancer. It is a scary diagnosis, but the survival rate is over 90% now. But heart disease, oh no, heart disease causes 1 in every 5 deaths of women in the USA. It is the number 1 killer. 695,000 women a year, whereas breast cancer kills about 47,000 a year. So still deadly, but not nearly as much as heart disease. And so if I can reduce my heart risk by 50%, by golly, I'm going to do it. Okay, myth number 6. Breast cancer survivors can never go on hormones. Okay, this is still controversial, but there is no reason not to take the vaginal hormones to prevent GSM. And there are expanding bodies of evidence that the topical hormones likewise do not increase cancer recurrence risk. Anyway, it's all about relative risk. So even if the original claims of the Women's Health Initiative are correct, the risk increases of developing breast cancer increases from 4 per 1,000 people to 5 per 1,000 people. And that's even if you're taking the old Prempro, which had medroxyprogesterone in it, which has really been proven to be not a great chemical. And I would not recommend taking that anymore. That increased breast cancer risk doesn't balance for me the fact that the estimates now show 50% reduction in heart risk if you start within 10 years of menopause, 30% reduction in colon cancer, reduction in dementia, reduction in deadly fractures and bone loss. All right, so here's some truth about menopausal hormones. 90+% of physicians trained since 2002 were not taught all these facts that I just told you in med school or in residency. Even GYNs and urologists who treat these kind of things every day. So if a doc knows these facts and knows how to treat menopausal hormones, it's likely that they sought out that training on their own. So I am now, at this moment as we speak, actually proctoring an online clinician's course now that teaches all the latest, including how to use supplements and FDA-approved preparations to balance and optimize hormone therapy for men and women. We had the introduction this past Sunday, and it was amazing. And we're going to continue every Sunday afternoon through Christmas. If you want to join us, the live sessions are free, and the replays and slides and other supporting documents are available for an administrative fee. So I put the website up there, and you can find that link at my sister website, which is www.allergyaccessmd.com/endo-opt-in. All right, that's it for now. I'm Dana Gibbs, MD. I'm an integrative physician in North Texas. I help people address their thyroid and other hormone imbalances. So if you're a thyroid or a chronic fatigue sufferer in North Texas, and you want a caring doctor to help you resolve your exhaustion, joint muscle aches, poor sleep issues, weight gain, come sign up for a new patient evaluation with me now at www.danagibbsmd.com. You can also send me an email at drgibbs, drgibbs at danagibbsmd.com to ask questions that I can answer in the next Tuesday live. That was great fun. I'm going to go ahead and sign off. Y'all have a good evening. Bye-bye.